Good evening, everyone. A warm welcome to all of you. My name is Dr. Sanjay Kamble. I head the medical team here at Samarth Life Sciences. It's my pleasure being the part of this scientific agenda, the program for today. This is all about the scientific agenda which Samarth as a life science company believes in having for the medical fraternity, which is beneficial finally when it comes to the better patient care. It's my duty to tell about something about the company as well before we go on to the actual program. So Samartha Life Sciences is an innovative care company that has got multiple innovative products which caters to multiple specialties. So Samgen is one of the division which caters to the products which are meant for the endocrinology. The Samartha Life Sciences began many years back with a humble startup, and then now we are a multi presence throughout the world, which we cater to various countries in African countries and some South American countries, as well as many more. To cater to the needs of all of this, we have robust plants here in India. So we have two plants at Baddi and the R&D center at Bangalore. And that's how we cater to all of these multi-specialties. And for that, we also have 10 strong divisions which cater to the marketing needs. So that was in a brief about the Samartha Life Sciences. And coming to the today's topic. So why we chose this day? So this is a day when the famous the US late US President John Kennedy is a birthday on 29th May, and he suffered from Addison's disease, and that's not, and that simply says that this should be the best day for spreading the awareness about this disease, and that's the reason Addison's disease has been celebrated today on 29th May 2024. So Mr. Kennedy suffered from a lot of complications throughout his life, even during his presidency, that resulted him to be fatigued, even hyperpigmentation on his faces, and that's why. To be more aware, so the day is presented today. So Addison's disease, this is a disease which was named after Thomas Addison, the British physician who first described the condition way back in 1855. And he described it originally as melasma suprarenale. However, then the physicians gave him the medical eponym as Addison's disease for the recognition of his discovery. So that is a very interesting history, and if somebody goes by it, this is how the histories are created, and finally, as the world has developed, we have come a long way after that. So the objective of today's program is to discuss on an integrative approach to manage adrenal insufficiency, as well as we'll discuss on the advocacy on the judicious uses of the glucocorticoids, mineral corticoids, and for that we have eminent speakers from different parts of the world. So, getting onto this, it's always my pleasure to introduce the speakers for the day. However, the chairperson I would like to introduce is Dr. Sanjay Kalra, sir. So, Dr. Sanjay Kalra is an endocrinologist at AIIMS, New Delhi. He is a consultant at Bharati Hospital, Karna, a visiting professor at AIIMS, Rishikesh. He's a past president, Endocrine Society of India, president, South Asian Federation of Endocrine Societies, president, Indian Professional Association of Transgender Health, educator at International Society of Endocrinology, chief deputy chairperson, advocacy and partnership working group at ISP, a member program organizing committee at International Congress of Endocrinology, Singapore, and section editor at Endocrinology and even in API textbook of medicine. So, sir has a lot of affiliations to go on. However, this was about in a short. And then with this, I would now hand over the stage to Dr. Kalra, sir, to initiate the program and also introduce the speakers and they take this agenda ahead. Over to you, Kalra, sir.
Thank you, Dr. Sanjay, and a warm welcome to everyone who is logged in today. We have people logged in from across the world, and we welcome all of us in this endeavor to learn more about Addison's disease, adrenal health, and to share information about how we can manage it. Our experts for today, they represent the best of the world. So a warm welcome to Professor Rakesh Sahai, who is from the Department of Endocrinology, Osmania Medical College, Hyderabad, India. He is also president of the South Asian Federation of Endocrine Societies, president of the Research Society for Study of Diabetes in India, and also president of the Diabetes in Pregnancy Study Group India. Warm welcome, Dr. Rakesh.
Thank you.
Our other experts are equally illustrious. Dr. Sarah Alam One of our best students, one of the best endocrinologists from India, and currently working at Dubai in the United Arab Emirates. Madam has special expertise in adrenal hypertension. So, warm welcome, Dr. Sara.
Thank you.
Dr. Sara had to migrate to UAE because she won all the prizes, all the awards, all the trophies that were there for, winning, that were there for competition in India. So there was nothing left for the poor little boys of the country. So Madam decided to move so that the boys of India could win a few prizes here and there. Otherwise, they were not getting any prize while she was around. So thanks, Sarah, for leading from the front. We also have Dr. Joseph Papachan with us. Dr. Joe is a consultant endocrinologist at Lancashire in the United Kingdom, and he's also honorary professor at the Manchester Metropolitan University, as well as honorary faculty at Kozhikode Medical College and Manipal University in India. Warm welcome, Dr. Joe.
Thank you.
Dr. Joe's expertise in writing and education is unparalleled. But one person from India who is at exactly the same level, the same pedestal, is Dr. Asha Madam. Warm welcome, Madam. Madam is Professor and Head, Department of Endocrinology at Christian Medical College, Vellore in India, and one of the leading academicians of the continent as well as the country. Warm welcome, Dr. Asha. We also have with us Dr. Imperia Brajkovic. Madam is Professor of Endocrinology and Internal Medicine at the Luis Razetti Medical School in Central University of Venezuela, and she also works in Spain. So she's truly a multi-continental, a trans-oceanic or transatlantic personality. Madam represents both Latin America and Spain at the International Society of Endocrinology, where she is part of the executive board. So warm welcome, Professor Brajkovic. And we have with us Dr. Jaco Obudu. He is Head of Endocrinology, Head of Department of Endocrinology Diabetology at CHU Yopougon in Côte d'Ivoire, West Africa. Dr. Jaco represents Africa at the International Diabetes Federation, and he is also part of the International Society of Endocrinology Advocacy Group. Many credits to him, but I think what I like most about Dr. Jaco's contribution is that he tries to get everyone together, the entire Africa and Asia together, Francophone, Anglophone, as well as Lusophone and Spanish-speaking Africa. He makes sure that everyone goes together and works together as a team. So warm welcome, Dr. Jaco. Now, when we speak of working as a team, an analogy that comes to mind immediately is the endocrine system. So many different glands, but all working together with each other. And Dr. Jaco, isn't that true? So what is more difficult, Dr. Jaco? Is it to get, let us say, Francophone and Spanish-speaking Africa together? Or is it more difficult to get the pituitary and the adrenal to work with each other? What is more difficult?
The two situations remain a very, very great challenge.
Both are challenging. Okay. So let's ask Dr. Imperia, Madam, how difficult is it to get maybe Portuguese Latin America and Spanish Latin America together? We need to unmute. Dr. Imperia.
Dr. Imperia, we can't hear you.
All of them are very warm people, so all together work together. The Brazilian people are very nice, and the Spanish, we share the same language, so we can speak and talk and work together.
And even Portuguese, Spanish, there is a lot of crosstalk. 80% is the same.
That's right. That's right.
So, Madam, would you like to extend this to the endocrine system? What are the kind of feedback mechanisms that we have? If we were to ask a question, which is the strongest endocrine gland in the body, what answer? Would you have an answer for that?
I think it's quite hard to say, but cortisol is very important. Otherwise, you are going to die. And the other ones, in a way, because I mean, growth hormone, you don't grow. Maybe ovarian and testicle where you don't develop, or you. But I mean, without cortisol, you cannot live. Thyroid is very important. Otherwise, I mean, it's quite difficult to say which one are the most important. I think all of them have the same place that works.
Oh yeah, all of them are equal. That is the importance of teamwork.
Right. That's right.
Dr. Rakesh, your comments on this. Is testosterone more important or estrogen, perhaps, which is more important for survival of species?
Yeah, so I think no, but as Madam just said that it's all of them are equally important, and isolating one of them as the most important is difficult to say. But cortisol stands out as the most important hormone, I would say.
And Dr. Asha, your comments. In endocrinology, usually we are attuned to talking about vertical feedback mechanisms. Vertical feedback would mean a hypothalamus and pituitary on top and the adrenal below. But do we have horizontal feedback mechanisms as well? Like, for example, when we speak of teamwork across the world, we all work together. We are all scientists or clinicians working for better health of mankind, womankind. So are there horizontal feedback mechanisms between maybe the adrenal and the kidney, or between other any glands? Anything that comes to your mind, madam?
Yes. I think the adrenal is the classical example of a horizontal feedback where the adrenal cortical regulation of aldosterone is based on the renin-angiotensin-aldosterone system, which is a horizontal feedback mechanism that is regulated by the blood pressure and the juxtaglomerular feedback from the kidneys and the sodium-potassium homeostasis. So in a way, there is vertical as well as horizontal feedback everywhere. And the pituitary, of course, plays the master role in regulating all the endocrine glands.
So, Dr. Joe, this story, all the glands went to a party and they, began an argument with each other. So the pituitary said, "I am in charge of all of you, so I am the strongest." Testosterone spoke the loudest, so he tried to shout everybody down. Estrogen came in wearing her best clothes, and she said, "Without me, the human race will not survive. So what are you all talking about? Estrogen and progesterone, we are the ones who keep the race going." Cortisol came and said that if you create stress, then I am the person who helps you. And there is actually something known as the koala bear syndrome. Koala bear syndrome happens in, it's also called CIRCI, CIRCI. So it happens in critical care units, where you see that some people are not able to mount a cortisol response to critical illness. And that is why they succumb to disease, because the cortisol does not respond to stress. It's called koala bear syndrome because the koala bear does not have an adrenal gland. It's a vestigial gland. And when you put the koala bear in captivity, the bear is just not able to handle stress. They just stop reproducing. They stop living. So all these glands, they began fighting each other. But then suddenly something happened, and someone reminded all the glands about the story of Noah's Ark and the flood. And they also reminded each other of the fact that once upon a time, all of us were aquatic animals. And then we came on Earth. So to your mind, what would be the strongest gland and what would be the strongest hormone, Dr. Joe?
I think, as others were mentioning already, every hormone is important, but cortisol may have a bigger role. As Imperi was mentioning, without cortisol, we can't survive. But if you look at the wider picture, without other hormones also, we won't be able to survive, but maybe slower. So in terms of the acuteness of illness, I think cortisol excess and cortisol deficiency both can be quite rapid and catastrophic in terms of the metabolic and the life-related connotations. So I think among these, of course, we are not dealing with all the hormones. Endothelium is probably the largest hormone producing organ in the body, but we don't deal with those things, minor things, but everything is mutually connected and they are interrelated. But cortisol may have slightly better role.
Let's talk about aldosterone before we move on to Dr. Rakesh's presentation. What helped us come on Earth as animals when we evolved? And if you were to think of one hormone that was kept safe on Noah's Ark, what would that be?
Again, aldosterone could be.
Again, the adrenal gland, yeah.
Adrenal
because
gland,
without aldosterone, you cannot sort of
maintain your
salt and water.
sodium and water homeostasis. So that's also equally important.
You can't keep your salt safe. And otherwise, all of us would be we would be living deep beneath the oceans, and maybe the same countries, the same names, but we would be having this webinar underwater then, if there were no aldosterone on Earth. But that's great, and we welcome everyone warmly again to this webinar. We have a wonderful set of topics for you. and our experts are here to share their expertise, their wisdom with us. We'd like to request Dr. Rakesh to begin. Dr. Rakesh, just 3 grams of adrenal tissue on each side, total 6 grams. But the strongest hormones come from there, cortisol and aldosterone. What kind of morbidity profile do we see across the world in terms of adrenal disease?
Yeah, so I think I'll just share a few slides and just give a brief overview of what we are going to actually discuss over the next 1.5 hours or so, where we have each one of these aspects being covered by the experts that are there. So I'll just share a few slides and just take about 5 minutes, 5 to 7 minutes, and then we'll move on to each one of them. Should I?
Sure.
Yeah. So as we have discussed about the importance of the adrenal gland, which is brought out that the both cortisol is probably one of the most important hormones, and also aldosterone. The significance of aldosterone was just discussed. So what I've just put together these slides to just show that if you look at the spectrum of adrenal disorders, we are looking at both cortisol deficiency, which could be because of the various type reasons for adrenal insufficiency. Then we have CAH, which is again an important cause of adrenal insufficiency. Then we have cortisol excess manifesting with Cushing's, with the plethora of manifestation that we speak of, and then little about a few chromocytoma, about which again we're going to have a lot of discussion about adrenal hypertension, whether it is because of FEOs or because of primary hyperaldosteronism, which has become a very important cause of hypertension. And then we have a little bit of adrenal cancers. So if we look at Addison's disease, the prevalence is to the tune of about 82 to 144 per million population. And as we are all aware, the most common cause across the globe, if you see, of adrenal insufficiency is autoimmunity. But again, we are going to hear from Dr. Asha about the unique causes that we see in tropical countries like ours. We see a lot of other causes for adrenal insufficiency. We see a lot of infections causing that, and a lot of other varieties of adrenal insufficiency, which she's going to speak about. So I'm not going to steal thunder from that. And then we are also, if typically we look at the autoimmune presentation, it's generally in the age group of 30 to 50 years, more frequent in women. And the presentation often can be, very, very subtle also many times. Pigmentation is a very common manifestation, and they may present with adrenal crisis in some of the situations, which again becomes a important adrenal emergency in amongst the endocrine problems that we see. And congenital adrenal hyperplasia is pretty common worldwide. We could say it's and the most commonest cause of this is the 21 hydroxylase deficiency. And if we look at the data from a large number of neonates worldwide, we see that the overall prevalence is about 1 in 15,000 live births. However, the prevalence rates may be different. In our ethnicity, we see a lot higher prevalence as compared to what we see worldwide. And so certain geographical areas have much higher prevalence rates of 21 hydroxylase deficiency. The non-classical forms, the classical forms present early in life, present with salt wasting crisis, while the non-classical forms is probably one of the most common autosomal recessive diseases across different ethnicities. And most patients with the non-classical form may not be identified by the standard single test newborn screening programs. And because these programs, the classical screening program targets classical picks up the patients with classical 21 hydroxylase deficiency, and it's based on the detection of very high levels of 17 hydroxyprogesterone in the blood spot that is taken, the heel spot that is taken. Now, when you look at the other end of the spectrum, where we're looking at excess of cortisol, we're saying that Endogenous Cushing syndrome is rare. It is seen to the tune of about 0.7 to 2.4 per million population per year. But more important than that is probably the endogenous Cushing's. Endogenous Cushing's is, or the iatrogenic Cushing's, because it may be because of various medications, steroids that are prescribed for a particular period of time, but patients end up continuing to take that. This is what we see in our country. We see that a lot of patients who have been prescribed steroids for a short duration end up taking it for a longer duration, because it is many times available across the counter. And the other issue is that they get relief from their symptoms for back pains or whatever sort of reasons that they've been taking. Many of them have been taking for skin problems, and they end up with exogenous Cushing's. So this is another important area that is going to be discussed. Then we have hypertension as a manifestation of endocrine disorders. We are looking at pheochromocytomas, which are the catecholamine secreting tumors, which are the prevalence. I mean, the incidence of that may be about 0.2% of all hypertensives. The annual incidence of pheochromocytomas may range from 0.8 per 100,000 person years, and this is likely to be underestimate, as 50% of pheochromocytomas were diagnosed at autopsy in one series. So, although this is what we are diagnosing, but a lot of it is picked up postpartum. In the postmortem series, also autopsy series. Pheochromocytomas can occur at any age. The most common age is, however, the 4th to 5th decades, and they're equally common in both males and females. And most of these tumors are sporadic, but 40% of them have a familial basis. And it's very important that we do a genetic screening today. It is important that we do genetic screening in all our patients with pheochromocytoma, because 40% of them have a genetic basis. And the hereditary ones typically present at a younger age and than the sporadic ones. Now, coming to primary hyperthyroidism, this is becoming recognized as a very important cause of hypertension, particularly amongst the resistant hypertension. If you're looking at the resistant hypertension, a major chunk of these patients with resistant hypertension turn out to have primary hyperthyroidism. We are going to hear about this in greater detail from Dr. Sara. So we'll look forward to that. And important, the prevalence rates, as I was mentioning, were ranging from 11.3% in patients with normotension, 15.7%, 21.6%, and 22% respectively in those with stage 1, stage 2, and those with resistant hypertension. So a major chunk of patients with resistant hypertension may end up with having primary hyperthyroidism. So it will be very important to screen for this condition in amongst all the hypertensives, and particularly so when you're dealing with a resistant hypertension. And 30%, 9 to 37% of them may have hypokalemia. Hypokalemia is not a necessary feature, and but we need to screen most of our patients with the resistant hypertension. Now, adrenal crisis is something which we should be aware of, and this will be discussed in the presentations. This has a very high morbidity and mortality, and hence this is something which we should be looking out for whenever in patients in the acute settings. In patients who have unrecognized adrenal insufficiency, they may end up with adrenal crisis. Finally, a little about adrenocortical carcinomas. These are reported. The reported incidence is to the tune of about 0.5 to 2 cases per million population per year, and this accounts for up to about 14% of adrenal incidentalomas. And most ACCs occur as sporadic tumors, but can rarely be associated with hereditary syndromes like Lee-Fromini syndrome and the Beckwith-Whitman syndrome. More common in females, can occur at any age, with a peak in the 5th and 6th decades of life. So I think I have given just a broad overview of the spectrum of endocrine morbidity that adrenal morbidity that is seen across the globe, and we have specific presentations from all the other speakers as we go along, and we are going to see more in detail about each of these conditions. Thank you.
Thank you, Dr. Sahai, and thanks to everyone for being with us. Any questions, any comments, feel free to share with us, and Dr. Sahai will be happy to answer. Before we move on to the next talk, perhaps we can ask Dr. Joseph. Dr. Joseph, your comments about adrenal morbidity in the UK. Anything extra that has been missed? Anything which you see more frequently than in other parts of the world?
I don't have the statistics, but it's not uncommon to have these patients developing acute adrenal crisis and issues, and rarely they die, but especially with those with poor compliance. Rarely I've come across cases dying from the acute medical take during their ICU stay with a delay in diagnosis. I think I don't have a statistic of the numbers who is dying out of adrenal crisis, but it's not uncommon, especially in those with poor compliance issues.
Dr. Imperia, you have experience of working in multiple countries. Any differences that you see in adrenal morbidity between South America and Europe?
No, I believe we could remember that COVID disease has been very often that they have adrenal crisis. And when you talking about long COVID, you also has you could have adrenal insufficiency. So that's have to keep in mind, especially with the virus and the people who already, the patient who has different glucocorticoids therapies. That was the people who has more risk to have adrenal crisis having COVID. And as that I think is important, the COVID, we learn many things from COVID with different glands, not only adrenal, thyroid, and diabetes and everything. And especially in my country, we will just have, but it's quite difficult sometimes to make diagnosis or a correct treatment.
Dr. Jacko, your comments. Madam said that sometimes it is difficult to diagnose adrenal disease. Do you and Dr. Asha, do you face this challenge as well in your practice? So, you suspect adrenal disease, but you are not able to confirm it because of lack of diagnostic facilities.
Yes, adrenal disease is more common in our clinical practice. As you say, is a very great challenge in the way of epidemiology, also in the way of screening, diagnosis because of cost of clinical or biological exams, but also according to treatment. Don't forget that we can have many causes of diabetes complication. They generally receive young women with PKA, with hypertension crisis. And after screening, we notice that was a focus. So most of medical practitioners doesn't know this disease. Very, very good problem. We are casting screening, diagnosis, and also for all level of medical practice, also in outpatient.
Yeah, so the point is that we need to raise the index of suspicion. Adrenal disease is quite common amongst us. Dr. Asha will be speaking to us later. Madam will be speaking about endemic forms, which we should know more about. Perhaps we can move on to Dr. Sarah Alam. So, Dr. Sarah, hypertension is one of the commonest diseases in the world, isn't it? Is all hypertension the same? And what insights have you gained over your career as an endocrinologist? What's the similarity between endocrinologist and Sherlock Holmes?
So I've been, good evening, everybody. And I've been given the topic of adrenal hypertension. And there is so much to cover on this topic in short time. I'll try to do justice. Regarding hypertension, which is like the adrenal hypertension, I think it is much more prevalent. And as Dr. Sahai rightly pointed out, we should screen more and more. unfortunately, like there's one extreme scenario where we talk about screening everyone. However, the ground reality is that even those who have severe hypokalemia, even those are not screened. So it's just the opposite spectrum, and it actually baffles me that nobody talks about primary aldosteronism. It's if you see on social media, people are talking about thyroid. Everybody knows about thyroid. If you ask the patients, have you heard about adrenal? So they don't know what's adrenal gland. I mean, they have no clue. So I think this is a good initiative, and people should talk about adrenal more, and it's much more common. I even the essential hypertension, it's a spectrum. So it's not black and white, like you have primary aldosteronism or you don't. It's all actually a spectrum, and the spectrum now, more and more papers are coming up that even it starts from the normotension, because that's like a subclinical stage. So that is another topic of discussion altogether, but I just want to emphasize that we should screen more and more and more. That's the message should be. So can I start my presentation?
Sure, certainly. And we need to be fast and furious like the hyperactive.
I think I have more slides, so I will try to be more. I will try to be faster. So adrenal, this is such an interesting heading. I would really credit the one who gave this heading, that it's actually we are like acting like a Sherlock Holmes, especially in younger patients who are presenting with hypertension. So if you talk about scope of the problem, scope is unlimited because hypertension is such an important public health challenge. And majority of patients, although hypertension is primary, subgroup may have secondary cause. So what are those patients who may have secondary cause? So if you look according to age, if you are seeing in the clinic a younger patient with the history of hypertension, especially severe hypertension, resistant hypertension, you should definitely, rather than just prescribing medicine, evaluate the cause. That is so important. So comes our role as Sherlock Holmes. So it begins with history taking, the good old history taking. That is the starting point of everything. So we begin with the onset, history suggestive of any renal disease, past history, family history, history of spells, taking blood pressure in both upper limb, lower limb, examining them. So that is the first step. This kind of proforma we had in All India Institute of Medical Sciences, where we'll just, at that time, it was a big task to fill them all. But then retrospectively, you realize that filling all the details, it's really important. So all of these, they are clues for Sherlock Holmes to actually know what is happening. So these are the routine biochemical investigations we did, and all the hormonal investigations. And then I'll be talking more about aldosterone and renin, which are the key heroes here. And of course, doing all the basic examination, not to miss out on other non-endocrine causes as well. Now, this is one slide which is so important to understand the cause of adrenal hypertension. So adrenal hypertension is due to excess of autonomous production of aldosterone. So it can either be aldosterone or something like aldosterone. So an aldosterone or any other mineralocorticoid. And in that case, renin will be low. So it is basically low renin hypertension, either due to high aldosterone or due to high something like aldosterone. So that is what we will be talking about. So the endocrine hypertension can be either adrenal dependent, thyroid, pituitary dependent, or genetic monogenic causes can be there. So coming to our cause, as Dr. Sahai gave in the overview also, pheochromocytoma, primary aldosteronism, then there is CAH, and then Cushing syndrome. So this is a very important figure. From here, you can understand which are the basic workup which is required. So pheochromocytoma, when to consider is the history, which can tell a clue. In pheochromocytoma, it's quite typical history, which with a paroxysmal symptoms. And how to evaluate is fractionated metanephrines. Primary aldosteronism, I will talk more about that. Then there is CAH, and we have the renovascular hypertension and other causes. So this is very important to take history properly. So basically, as I told previously, the hypertension can be low renin with high aldosterone. So that is basically primary aldosteronism with different forms of primary aldosteronism, or low renin low renin and low aldosterone, which can be due to CAH. Basically, it is high deoxycorticosterone, or it's apparent mineralocorticoid excess due to genetic cause. So now coming to pheochromocytoma, although pheochromocytoma we like to evaluate for pheochromocytoma, like endocrinologists like to evaluate them, but it's really very rare. So we are talking about less than 0.1% of hypertensive patients who will harbor a pheochromocytoma. However, there are some factors or some clues in the history. If they are, like, for example, a patient coming with a labile hypertension and an adrenal mass, of course, we have to think about pheochromocytoma. So the pre-test probability will be depending upon the history and the other features. So these are the common symptoms. Pheochromocytoma is said to be a great masquerader. So it has a lot of variable symptoms. And they can be headache, sweating, and palpitation constitute the classic triad of pheochromocytoma. Then while workup of pheochromocytoma, it's very important that there are a lot of drugs which can interfere, and then it's important to discontinue them at least 2 weeks before the evaluation. This is the workup chart. So discontinue the interfering medication. Then the workup depends upon the pre-test probability. If the pre-test probability is high, we can go with even plasma fractionated metanephrines or the 24-hour urinary fractionated metanephrines. But if it is low, we have to go with the 24-hour urinary fractionated metanephrines. And then the second step is localization. We have to do the adrenal imaging and then functional imaging to confirm. And then genetic testing, of course, and then surgical resection. Now coming to Cushing syndrome. So Cushing syndrome, as we discussed initially, that exogenous glucocorticoid administration, unfortunately, is one of the most common cause. Then the endogenous can be endogenous Cushing. Again, it's a rare condition. We see more during our training because we are at referral center, while in our clinics, we are basically more of seeing the exogenous glucocorticoid administration. So this is a chart of workup of Cushing. First is confirming the diagnosis, which can be by either 24-hour urinary free cortisol or by taking midnight salivary cortisol and dexamethasone suppression test. Then the second step is to the plasma ACTH, and the causes depend upon ACTH dependent causes, ACTH independent cause. Since we are talking about adrenal today, so the adrenal is in this, ACTH is suppressed. So then we do a CT scan, and then we can find out what is the cause. Now coming to what other cause, like low renin and low aldosterone. So it is some other factor which is acting like a mineralocorticoid. So it is basically, if we see this chart and we remember it, this chart we have read hundreds of times, and of course have to re-look at least I have to re-look again at this chart. So in this one, this is basically adrenal steroid synthesis. And in this one, any cause which is increasing the mineralocorticoid or its precursor can cause hypertension. So if aldosterone is being increased, that is high aldosterone and low renin, or if anything if the precursor is increased, that will also cause hypertension. So in CAH, the two basic causes are 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency. And this will appear when we will do the test as low aldosterone and low renin, because aldosterone is low, but the precursors are high. Now, coming to the most common cause, which I really want to talk about, because it's not like Cushing or FEO or even CAH, which are less rarer and we see less often. If you start screening for primary aldosteronism, I believe you will really find a lot of cases. So coming to primary aldosterone, it's most common cause of secondary hypertension, and it's almost like 10%. Imagine 31% of population have hypertension and around 10% at least. That's even a conservative estimate. Maybe it's even more. So they have primary aldosteronism. Why should we screen for primary aldosteronism? So previously it was thought that it's a benign condition. But aldosterone is not benign. It can affect everything. It can cause affect gluconeogenesis. It can cause dyslipidemia, hypertension, cardiac fibrosis, vascular endothelial dysfunction. So aldosteronism is neither rare nor benign. So that is one thing, if we remember, that's like, it's not rare and not benign. Very important to understand this. So why should we screen? Because if we match essential hypertension patients and aldosteronism patients, they have 4 times increases for stroke, 6 times for MI, 12 times for AF. And this one, the specific medications, they are the game changers. So we should screen for PA. So it's not just the matter of controlling blood pressure, it's a matter of nullifying the aldosterone. That is the key. So whom should we screen? That's a very important question. Previously, this is our study, which was published in Clinical Endocrinology, and it was shown that young hypertensive patients, 18.8% patients screened positive, and prevalence, it was found that 17.8% patients had confirmed primary aldosteronism in young patients. So especially the young patients, we should definitely screen for primary aldosteronism. Then there's a similar study from KEM Mumbai. They also found a prevalence of 4%, but they took patients with type 2 diabetes mellitus. So coming to the traditional. So the traditional is like hypertension with hypokalemia, resistant hypertension, adrenal incidentuloma, then severe hypertension. But newer concept, all patients with hypertension. Then what is the cutoff? Older cutoff, 15 at least, but now it's like, it's a spectrum. So at least anything aldosterone more than 10 and suppressed renin constitute a positive screen. Just forget about the ratio, just look at individually aldosterone and renin. So even the current Japanese guidelines, they recommend screening all hypertensive subjects. This is the older, this is from 2020 guidelines, and they have included now hypertension at a young age, which was not previously there as a screening criteria individually. So hypertension as a young age should be considered as a separate category. This is again from 23 Korean guidelines, and they cited our study. They also included, other than the traditional screening indications, hypertension at a younger age to be included. So ideally all patients, but at least those in the guidelines should be screened. Like anybody who is having resistant hypertension, who is having severe hypertension, they should be screened for primary aldosteronism. Ideal routine screening on first presentation for hypertension. But the reality is poor screening rates worldwide. This is data from the developed world. We don't have even the other countries' data. It shows that just 2% hypertension are screened. Why? Why do we have such poor screening rates worldwide? The reason is that less than 1% of patients who should be screened are screened. The reason is that the diagnostic algorithm is considered so complex that it's considered daunting. And secondly, of course, there's not enough awareness about this condition. How to screen? This is the classification which I initially discussed, that aldosterone producing adenoma, bilateral hyperplasia, and then familial hyperaldosteronism are the causes of classification. This is the algorithm, which is simple. All patients test at least once. Just take a morning sample, simple, plasma aldosterone and renin. If more than 10 aldosterone suppressed renin, it's positive. Do the confirmatory test, and then the next step after the confirmatory test is the CT scan. If the CT scan shows clear-cut adenoma and the patient is young is less than 35, then we can directly go for surgery, otherwise do adrenal venous sampling. So these are the medications which can interfere with aldosterone-renin ratio. However, you can screen and continue with all the usual medications. If possible, to stop spironolactone for 4 weeks, but all the usual medicines can be continued. One very important thing is that hypokalemia must be corrected, because potassium is a very powerful regulator of aldosterone. So that will get a false result. It's very important to correct potassium and ask the patients to not to restrict the salt. If taking spironolactone, withdraw it for 4 weeks, like spironolactone, eplerenone, withdraw them. Other medications can continue. The cutoff is also, there's a big debate on the cutoff. Rather than going for this traditional cutoff, just see the absolute value of aldosterone and renin. Different guidelines, they mention different cutoffs. Regarding the confirmatory test, again, lot of variability. We were using saline infusion test as a cutoff. Now there's a seated saline infusion test in which more than 6, if it is there, post 6 nanogram per deciliter aldosterone is considered positive. So now the newer concepts. One newer concept is that all patients should have their at least renin tested. Those who have suppressed renin should be referred to an expert center. And then there is a 24-hour urinary sodium level and aldosterone level, which is being done. And now it's being studied like a spectrum. Why should we do subtyping? Why not just start spironolactone in all the patient? So the reason is that if the patient is having adenoma, then of course there's a chance for cure, and just maybe the MR antagonist therapy is not enough for them. So severe, if they have the severe form, then surgery is the optimal treatment for them rather than just giving them spironolactone. Incomplete evaluation and incomplete treatment is suboptimal management. Coming to adrenal venous sampling. Adrenal venous sampling is performed to assess whether autonomous hormone production is unilateral or bilateral. This is our AIMS protocol, in which we collected first from right adrenal vein, then infrarenal IVC, then left adrenal vein, and infrarenal IVC. These are the indices which we used, and lateralization index, if the aldosterone cortisol ratio is more than 4, it suggested unilateral primary aldosteronism. Now, there are a lot of nuclear studies which are coming up. Hopefully, in future, we might do away with adrenal venous sampling, which is a complicated procedure, but still it's not standardized, and still AVS is considered gold standard. So we saw this very challenging case of a young girl who had a 24-year female who was on 6 antihypertensive agents and drinking potassium in such high doses, yet had hypokalemia. In this case, she had one of the highest aldosterone level I've ever seen in my life. Her aldosterone was 2070. Just imagine, we are talking about 10 as more than 10 as positive. She has 2070 nanogram per deciliter. The ARR was extremely high, and then she had a KCNJ5 mutation, which confirmed the diagnosis of familial hyperaldosteronism type 3. She underwent bilateral adlectomy and she is now doing well. She has normal potassium and she's off antihypertensive agents. Now coming to this very interesting this algorithm given by Dr. Vaidya, who is working from Harvard. First thing to do is to measure aldosterone and renin. Look at renin. Don't look at the ratio. Look at renin. If renin is suppressed, then look at aldosterone. If aldosterone is also suppressed, then primary aldosteronism is unlikely. If aldosterone is more than 15 and have hypokalemia, it is overt aldosteronism, just go directly to CT scan. But if it is in the middle range, then there are two options. Also going for an empiric MR antagonist therapy if the patient is not willing for further workup. However, it is better to complete the workup, and in this case, we will do a confirmatory test and do a CT scan and then imaging and AVS to confirm. So the first step is to look at renin. Now, once we have the confirmed primary aldosteronism, we can do AVS and do adrenalectomy. If bilateral disease, then we can go for lifelong MR antagonist therapy. One very important thing, while the patient's on MR antagonist therapy, we have to give optimal dosing. So what is the optimal dosing for MR antagonist? So it's that the renin should rise. If you are treating it properly, you should measure renin. And the renin should increase. If it is still suppressed, despite being on MR antagonist therapy, it means that you are not treating it properly. So these are some of the aldosterone renin report, which we see in the clinic. It's very confusing. They report it in such a way that you are totally dumbfounded by these reports. So instead of seeing these values of ratio, just see the aldosterone and renin individually. And you can say whether it's positive or negative. So in this one, aldosterone is 40.4, which is positive. Direct renin is 9. Less than 12 is called suppressed, so it is positive. In this case, it is very clear it is positive. Aldosterone more than 100, direct renin suppressed. In the third case, also aldosterone 33, direct renin low. It's also positive screen. And in this last case, also aldosterone is 9.28, direct renin 0.5. And this one is positive. But if you look at all the units, it's funny the way they are reporting all kind of units. Like there's no standardization. Somewhere they will report as nanogram per MIU, somewhere nanogram per deciliter per micro IU per ml. So you are if you don't have previous experience in dealing with cases, you will be baffled by these reporting of different labs of aldosterone and renin. So I just lastly would say that primary aldosteronism, adrenal hypertension, we are not even addressing the tip. So the big chunk is below, and we need to do more. I would like to give special thanks to Professor Rajesh Karkawat from AIIMS New Delhi, who was my chief guide during my dissertation. Thank you.
Thank you, Dr. Sera. Wonderful explanation of a very difficult topic, actually. And you've touched not only the diagnostic part, but also the fact how full diagnosis leads to proper therapy. And if you don't diagnose properly, the treatment may end up being wrong. If you allow, Dr. Sera, we'll continue with the other topics and we'll wait for questions from the audience as well as comments from everyone else in the house. But let's ask a question before we move on. Dr. Imperia, Dr. Jacko, how common is adrenal hypertension in your setting? And do you have experience when you started a screening program, suddenly the prevalence of adrenal hypertension went up because you began screening for it? Dr. Imperia, Dr. Jacko?
Well, in my country, in Venezuela, we had had many cases, but we don't have protocols formally. In Spain, recently, we have a patient who is 55 years old and have high blood pressure since the age of 40, and no one thought that was primary aldosteronism, and they have a unilateral adenoma, was successfully removed.
Dr. Jacko, your comments? Any research going on in this in West Africa or across the continent?
It is a serious challenge in our countries. Even we have one of the greatest cardiology centers in West Africa, Abidjan. They are faced with many common situations, but we need more collaboration between different departments, cardiologists, endocrinologists, and general practitioners. Fortunately, not correctly established. So, in cases I receive some of them, but I'm sure that many of them dead or have complication before screening or before correct management. So it's a very, very good challenge, and we are working on it. So when we will come in Abidjan during our congress with your contributions, ASEAN, Indian contribution, put network go through this situation. I'm very, very optimistic about this. We have to do more. We have to do more. In many cases, like under diagnosis, cortical adrenal corticosteroid exist, and other diagnosis. So that.
Thank you. Dr. Joseph, Dr. Asha, your comments. How common is secondary hypertension, adrenal hypertension, specifically hyperaldosteronism in your setting? Dr. Asha first, perhaps, and then Dr. Joseph.
Yeah, I think it's a matter of suspicion, especially in patients with resistant hypertension, hypertension with hypokalemia. So these are the patients who need to be investigated. And of course, we cannot screen all hypertensives for adrenal hypertension, though we would like to. But definitely, these kind of patients need specific attention. And it is a significant problem. Being a referral center, probably we are seeing more, but it seems to be a significant problem in India as well.
Dr. Joseph?
I think it's grossly underdiagnosed across the globe, especially the primary aldosteronism. Adrenal hypertension, other than aldosteronism, are all rare. As Dr. Sahai was mentioning, the prevalence is so less common that we don't need to routinely look for things like pheochromocytoma as well as Cushing syndrome in those patients. But primary aldosteronism is quite common. Only the tip of the iceberg we see in our clinical practice, and the awareness is quite poor, even among endocrinologists and physicians, unfortunately. I've been with Michael Stovall, sir, in end of March in a plan to develop a resistant hypertension service here in my hospital. He has the maximum number of proven aldosteronism in the world, more than 2,600 cases. And I think across the globe, the awareness is increasing because of the these kind of meetings where we discuss this kind of problems which we need to highlight in your clinical practice. But it's quite common, and you often get referrals, especially in younger individuals with hypertension and those with resistant hypertension. We have to definitely screen for primary aldosteronism without doubt.
Thanks. And like Dr. Sera said, hypertension, it's not a binary construct, like either it's adrenal or it's essential. It's a wide spectrum. Similarly, Dr. Joseph, metabolic syndrome is an even wider spectrum and so ubiquitous. Sometimes we feel that more than half of humanity has got metabolic syndrome. So metabolic syndrome comes with its own set of clinical features, complications, comorbidities, concomitant medications. And then Cushing syndrome also has similar presentations sometimes. So what is your take on this statement? We'd like you to discuss about this. Metabolic syndrome is a precursor of Cushing's syndrome.
In fact, when you asked me to talk about this topic in short notice, I was thinking, oh, it's quite easy and simple, straightforward to work on it. But while reviewing the literature, since there's not much of published work on this topic, but it's quite interesting that we often underdiagnose this kind of issues. Metabolic syndrome and obesity is such a common and highly prevalent disease across the globe, even in developing countries like India and Asian and African and the South American continents. So I have a brief presentation on this topic. I'll share my screen. Sorry, that's my presentation, probably because of the, I don't know whether the slides.
Perfect. We can view it. Yes. Perfect.
Right. Okay. Metabolic syndrome is a Cushingoid precursor. This is the topic of my talk today. In fact, they are mutually connected. Metabolic syndrome is quite common in Cushing syndrome and vice versa. Cushingoid presentation is common in metabolic syndrome. So definition-wise, metabolic syndrome is an insulin-resistant state that we all know. And insulin resistance, hyperglycemia, elevated blood pressure, abnormal lipids, and abdominal obesity. These are the constellation of symptoms and features of metabolic syndrome. This increases the risk of cardiovascular disease and type 2 diabetes, especially with the obesity pandemic across the globe. Definition-wise, if you look at obesity, the Indian subcontinent and Asian subcontinent, the obesity cutoff by body mass index is very different. And in the Indian subcontinent, anybody with a body mass index of more than 25 is considered as obese. Whereas in the Western world, more than 30 is the cutoff. So it's always better to take abdominal adiposity as the important risk for metabolic syndrome. And if you have two additional diagnostic criteria, either diabetes or prediabetes, elevated non-HDL cholesterol level, high normal blood pressure, or hypertension. It can be in different forms, as you can see from the slide. I'm trying to cut short because of the time constraints. So if you have abdominal adiposity or increased body mass index, along with 2 or 3 additional diagnostic criteria mentioned here in the slide, indicates metabolic syndrome. In fact, it is part of the obesity pandemic, and more than 30% of the Western world is already obese, and that's going to be more than 40% in near future in Americas as well as in the Europe. So this causes the problems in metabolic syndrome, such as prediabetes or diabetes, hypertension or high normal blood pressure, and atherogenic dyslipidemia, which tremendously increase the cardiovascular risk. Metabolic syndrome and abdominal adiposity can be associated with a lot of illnesses in every organ system in the body, which can cause abnormal kidney function, metabolic associated fatty liver disease, heart failure with preserved or even reduced ejection fraction, sleep apnea, polycystic ovary syndrome, sympathetic overactivation and tachycardia, hyperuricemia, which all result in a chronic inflammatory state that is associated with the syndrome. Looking at the evidence, if you consider cortisol as a precursor for metabolic syndrome, as you all know, cortisol as secretion depends on the hypothalamo-pituitary adrenal axis and the circadian rhythm of cortisol production and the level of 11-beta hydroxysteroid dehydrogenase levels. The 11-beta HSD1 catalyzes the conversion of inactive metabolite cortisol to active cortisol, and it also amplifies the good glucocorticoid receptor activity. Whereas 11-beta HSD2 catalyzes the conversion of cortisol to cortisone. This is mutually regulated. In fact, obesity and insulin resistance are associated with increased expression of 11-beta HSD1 levels, whereas suppressed expression of 11-beta HSD2 levels. This increases the local cortisol levels. As you can see from this schematic representation, cortisone in the presence of 11 beta HSD1 is converted to cortisol, which is the effective steroid hormone, acting on the glucocorticoid receptors, effector cells, increasing the... Are you okay? Right. Increase the gene expression and also the effective effector in the effector organs. Cortisol is converted to cortisol, and it's the loop we can see. So cortisol binds to the cortisol receptors in the glucocorticoid receptors. Inactivation of the circulating cortisol by 11 beta hydroxysteroid dehydrogenase 2 in the kidney, and reactivation in the peripheral tissues as shown in the diagram. So glucocorticoid receptor induced local activation also can occur, increasing the intracellular cortisol availability. In fact, metabolic syndrome is associated with increased activity of the 11 beta HSD1, and that results in increased local steroid response and increased HPA axis activity. The resultant raised tissue as well as systemic cortisol levels play an important role in the development of metabolic syndrome. As I mentioned initially, they are mutually connected and mutually complementary. If we have something to stop the activity of 11 beta HSD1, it may have therapeutic effect in obesity and metabolic syndrome. Obesity is also associated with increased gene expression of 11 beta HSD1, and that increases the subcutaneous adipolysis, increase the HPA axis driven cortisol secretion, and these effects can be restored by bariatric surgery and loss of weight. These are all recent evidence coming up in the horizon. Cortisol may have a pathogenic role in the development of central adiposity, as described by Bujalska et al. In early 1990s. They analyzed the cultured omental as well as subcutaneous tissue adipose stromal cells, finding exclusive expression of 11 beta HSD in these cells. This increased activity of 11 beta HSD in the omental fat compared to subcutaneous fat led to the proposal that visceral obesity is a Cushing syndrome of the omentum. This increased local cortisol generated will increase the adipolysis and promotes pre-adipocyte differentiation of adipose tissue, increasing the adipocyte hypertrophy and consequently result in obesity. If you look at Cushing syndrome, that causes metabolic syndrome because of the abnormal the activity of the cortisol in tissues. And if you estimate if you measure the plasma, salivary, and urinary cortisol, because they are all having short half-life, you may not be always able to identify subclinical Cushing. However, if you look at scalp hair, which grows at a rate of only 1 centimeter per month, it may show increased cortisol levels in the scalp hair. And it has been found that increased cardiovascular risk, diabetes and metabolic syndrome and obesity are seen in those with high hair cortisol levels. Cushing syndrome, again, as I mentioned previously, can cause the metabolic syndrome phenotype by increasing the abdominal adiposity, increased association with hypertension, diabetes, dyslipidemia, and metabolic syndrome at high prevalence rates. Glucocorticoids increase the levels of glucose and increase hepatic gluconeogenesis, disrupting the insulin signaling in the liver, skeletal muscle, adipose tissues, and consequently increased glucose disposal, decrease the glucose disposal in the periphery, resulting in diabetes. Chronic glucocorticoid excess promotes accumulation of fat deposits in the liver, skeletal muscles, and pancreas, all those things can lead on to visceral obesity in Cushing syndrome patients with a very high prevalence of 25 to 50%, 100%, especially if it is slow, indolent, and chronic. Visceral obesity in Cushing's disease is associated with increased adipocyte hormones. It's also associated with increased metabolic activity, resulting in increased cardiovascular risk. Chronic glucocorticoid excess also stimulates lipolysis, mobilization of the subcutaneous fat tissue, and increased ectopic fat distribution in the form of buffalo hump, abdominal adiposity, and central obesity. This is a schematic representation of the adipocyte biology in Cushing syndrome with the steroid excess. You can see there is reduced brown adipose tissue, which is calorigenic, which is metabolically active and metabolically healthy, whereas you have abnormal lipid accumulation in different tissues, increase in the activity of 11-beta HSD1, reduced lipogenesis, increased lipolysis, and an inflammatory state. It also increases the food intake by hypothalamic stimulation. It can cause hepatic steatosis. It can worsen the pancreatic function, reducing insulin secretion, incretin secretion, and increasing glucagon production. It can also increase visceral fat tissue deposition in the epicardial fat tissues. This is the picture which shows the interconnection between abnormal glucocorticoids and metabolic syndrome. I'm not going to the details of that because of the time constraints. So metabolic syndrome causes hyperglycemia, dyslipidemia, central obesity, and hypertension, which in turn causes the structural and functional changes in the cardiovascular tissues. It causes increased coagulopathy, atherosclerosis, vascular remodeling, endothelial dysfunction. All these things increases the cardiovascular risk. Even treated cases of Cushing syndrome can be associated with increased CVD risk because the metabolic abnormalities and the obesity wouldn't go immediately after the treatment. So you have to be very careful with this kind of patients. We can there's clear evidence that there's increased aldosterone production in patients with metabolic syndrome. Maybe one of the reasons for hypertension in these patients. So there is inappropriate aldosterone secretion from the adrenal glands, local adipose tissue production of aldosterone possibly, and adipose tissue derived adrenal aldosterone secretagogue effect. Therefore, obesity is associated with increased mineralocorticoid production and mineralocorticoid receptor expression. Both cortisol and aldosterone and the receptor activation are important for obesity and metabolic syndrome. This is another graphical representation of how obesity involves increased aldosterone production and synthesis, resulting in hypertension. It has been found that mineralocorticoid receptor antagonists now in horizon. This is an important emerging concept. Treatment with mineralocorticoid receptor agonists in patients even with mild hypertension may have protective effect in cardiovascular health and metabolic health. And aldosterone synthase inhibitors are upcoming. There are a lot of new publications coming up. All those things should help us to improve the disorder, the metabolic syndrome, which is a Cushingoid state in a nutshell. So in summary, metabolic syndrome and Cushing syndrome are closely interconnected. Though there are several mechanisms mentioned previously, the exact pathobiological aspects of this new entity is still elusive. Appropriate control of obesity and adiposity by medical therapy, lifestyle changes, or bariatric surgery are the cornerstones of managing metabolic syndrome, especially if there is significant comorbidity, and it can improve the Cushingoid state. This approach should help to improve the cardiovascular risk, and appropriate use of medications, including mineralocorticoid antagonists, mineralocorticoid synthesis inhibitors, enzyme inhibitors, and appropriate treatment of obesity should help us to address the huge cardiovascular risk related to metabolic syndrome. Thank you. I'm happy to discuss if there's anything which I can contribute to the panel discussion.
Thank you, Dr. Joseph. You suddenly opened our eyes to such a wide spectrum of medicine now. Very tiny adrenals, just 3 grams. Cushing syndrome, we used to think is a very rare kind of a disease. You see it very rarely, and it's a very exotic disease in many medicine wards. But now suddenly you've made us realize that each and everyone coming with metabolic syndrome, at least we should think about Cushing's. And the overlap between metabolic syndrome, Cushing's, hypogonadotropic hypogonadism, polycystic ovary syndrome. I mean, there are so many things to think about, and you need that Sherlock Holmes, the way Dr. Sarah Alam said. You need to be a very good, comprehensive kind of a Sherlock Holmes to figure out who has which syndrome. Dr. Jacko, Dr. Jacko, Dr. Sarah, your comments on Dr. Joseph's presentation. Anything new that you've learned today, Dr. Jacko?
Yes, I have a small problem. My internet was cut off because the energy was cut.
Okay.
But what I can say for this presentation is a very interesting presentation. And what we have to know is people should have one pathology and have the second. I mean, people with metabolic syndrome can develop a Cushing syndrome and vice versa. But what is important is that we should not make any confusion about these two conditions. They are not the same. I can say they are opposites in front of the partition of motives. You know what I mean?
Yeah.
So
Thank
it's
you,
very
Dr.
important to know this difference, but also to know that these two conditions may be associated.
Dr. Sarah, please.
I think we should be more open to newer concepts, and I think I have learned a lot from excellent presentation by Professor Joseph. And this is the point, the raising the awareness and learning new things for today, many things which we don't know and newer concepts which are coming up. We don't think that way, so it's completely. What do you think?
It stimulates our adrenals and hypothalamus and pituitary to think in a more comprehensive manner. So thank you, Dr. Joseph. We'll move on to our next talk now. Professor Asha is with us. Madam, like we said, is president head of CMC Vellore. And Vellore caters to not only one state or one country, but to multiple countries. People come from across the globe to seek treatment. So, Madam, when we speak about adrenal morbidity, some things are secular, they occur across the world, but then there are other endemic forms of adrenal disease. Would you like to speak about some of the endemic forms that you've encountered in your practice?
Yes, sir. Thank you. And I would like to share a small presentation, if that is okay.
Sure.
So when we look at the adrenal glands, as we have been discussing in this webinar from the beginning, we have been talking about the most important hormones coming from the adrenals, the cortical hormones, mainly aldosterone, cortisol, and DHEA, and from the medulla we have the epinephrine. And the insufficiency of adrenal hormones could be either due to a primary defect in the adrenals when it is called the primary adrenal insufficiency, or it could be a defect at the level of the pituitary due to a tumor or due to an inflammatory disorder commonly, which is secondary adrenal insufficiency, or tertiary due to suppression of the hypothalamus and the entire HPA axis due to drugs. So about the diagnosis of adrenal insufficiency, the diagnosis is made by demonstrating a low serum cortisol in the morning, less than 5 micrograms per deciliter, in the morning or following ACTH stimulation, a cortisol level below 18 micrograms per deciliter. And this in presence of an elevated ACTH value more than 2 times the upper limit of normal would indicate primary adrenal insufficiency, whereas in presence of a low ACTH would indicate secondary adrenal insufficiency. Looking at the etiologies of primary adrenal insufficiency, the most common etiology described is adrenal destruction all over the world. And of this, in the Western literature, the most commonly described etiology is adrenal autoimmunity, either as isolated adrenal insufficiency or as part of polyglandular autoimmune syndrome, paroxysmal defects, mitochondrial defects, adrenal hemorrhage, adrenal trauma following adrenalectomy, or various infectious causes of adrenal insufficiency. The other causes being adrenal infiltration due to either primary adrenal lymphoma, metastatic cancers, amyloidosis, sarcoidosis, hemochromatosis, etc. Drugs like ketoconazole, rifampicin, phenytoin can alter the cortisol metabolism and thereby can precipitate an adrenal insufficiency in those with borderline functions. Steroidogenesis can be impaired due to defects in the adrenal steroidogenic pathway, all along the pathway through various enzyme defects, and very rarely adrenal dysgenesis or ACTH resistance have been implicated. Looking at the diagnostic algorithm which has been provided by the Endocrine Society, the Endocrine Society guidelines recommend that all patients with primary adrenal insufficiency should first have their 21-hydroxylase antibody tested for diagnosis, followed by, if the antibody is negative, then to do a CT adrenal to look for infiltrative disorders, adrenal hemorrhage, infections, or malignant tumors. And in males, very long chain fatty acids when there is a clinical suspicion of adrenoleukodystrophy. So when it comes to the etiology of adrenal insufficiency, what has been reported from the West is that about 80 to 90% of the cases are due to autoimmune destruction of the adrenal glands, whereas in our country as well as neighboring Southeast Asian countries, we have several reports of adrenal infections, and the number of reports have been progressively increasing over the last decade. So this is one of the largest study reported from India, from the Sanjay Gandhi Postgraduate Institute, Lucknow, where they have characterized the etiology of 89 patients with adrenal insufficiency over a period of 14 years, where the mean age was about 47 years with a mean follow-up of 6 years. The diagnosis of adrenal insufficiency was established as per the standard criteria, and elevated plasma ACTH defined it as a primary adrenal insufficiency. About 86 patients underwent abdominal imaging, of which 60 out of them, that is about 70% of patients, had bilateral adrenal enlargement on imaging, and among them, 60 patients underwent an adrenal biopsy. So looking at the etiologies of adrenal insufficiency here, autoimmune adrenal insufficiency was diagnosed based on the presence of 21-hydroxylase antibodies, adrenal histoplasmosis by the demonstration of histoplasma on adrenal biopsies, adrenal tuberculosis by demonstration of caseating granulomas or positive smear or culture for Mycobacterium tuberculosis, or in the absence of a specific proof, response to ATT was also considered as proof of adrenal tuberculosis. So what is noteworthy here from this pie chart is that a large proportion of the cases were due to infectious causes of adrenal insufficiency. About 45% were due to adrenal histoplasmosis and 15% were due to tuberculosis. So about 60% of the cases were due to adrenal infections and 22% due to autoimmune etiology. And among the remaining, we had about 5 cases of lymphoma and 3 cases of metastasis, along with the small numbers of other conditions. In 4 patients, the diagnosis could not be established. Another study from South India, from Madurai, which looked at the etiology of adrenal insufficiency in 36 patients, found that 14% of their patients had adrenal tuberculosis, whereas 50% were of presumed autoimmune etiology. Coming back to the study from SGPGI, a large proportion of the patients presented with fever and about 47% presented with adrenal crisis, which could be life-threatening. Looking at the various etiologies of adrenal insufficiency, about 63% of patients with adrenal histoplasmosis had pre-existing diabetes, suggesting whether this could be a risk factor for developing adrenal histoplasmosis. And about 50% of these patients were farmers, soil being the main source of the infection. Among patients with adrenal tuberculosis, about 31% had other sites of involvement by tuberculosis. And among those with autoimmune adrenal insufficiency, more than 50% had other autoimmune endocrinopathies. The treatment of adrenal histoplasmosis, in severe cases, the treatment is with amphotericin B to begin with. The liposomal form is associated with better tissue penetrance as well as lower toxicity, and followed 1 to 2 weeks later by oral, step down to oral itraconazole, 600 milligram per day initially, followed by 400 milligram per day, and treatment is continued for about 12 to 18 months. And it should only be discontinued when the infection is completely cleared. The mortality in this series was about 45%, and the most frequent cause of mortality was progressive infection, adrenal or adrenal crisis. Looking at the epidemiology of adrenal histoplasmosis, it has been reported all over the world, mostly from the Central and South American region, Sub-Saharan Africa, as well as Southeast Asian countries. And in India, it's reported from all over the country, but mostly from the Ganges and from the north and northeastern parts of the country, but also in the southern part of the country. So looking at the data, pooled analysis of published data on disseminated histoplasmosis from our country, from 95 studies, including more than 200 patients, about 33% of these patients only were immunocompromised. So it does occur in immunocompetent patients as well. And adrenal involvement was significantly more common among the immunocompetent than the immunocompromised, though mortality due to adrenal histoplasmosis was more so seen in the immunocompromised patients. The clinical presentation in our series also, we found that adrenal insufficiency was the most common clinical presentation, and the other presenting features including skin lesions, generalized lymphadenopathy, oral or tongue ulcers, and one patient actually presented with generalized tonic-clonic seizures due to ring-enhancing lesions in the brain. The diagnosis, one could suspect a diagnosis of adrenal histoplasmosis based on the typical symptoms, the occupation which the patient is more common in males and those who are involved with working with soil. They also have anemia, thrombocytopenia, and elevated ESR because of the reticuloendothelial involvement, as well as hepatic involvement could lead to elevated transaminases and alkaline phosphatase. A contrast-enhanced CT abdomen would show diffuse adrenal enlargement, which appears hypodense and uniformly enhances with contrast. And the definitive diagnosis is by biopsy of the adrenal, which would show the characteristic organisms within the macrophages, the budding yeasts within the macrophages, demonstrated by Gomori methenamine silver or Jamesa stains or PAS stains. The other methods of establishing the diagnosis would include culture or DNA probe testing. Antigen testing is a relatively easy test which is currently available all over the country, and it has a good sensitivity of 92%. Antibody testing can also be performed. That would also be helpful. The treatment of this condition, as I said earlier, is with in severe cases with amphotericin B, and in less severe cases with itraconazole. And the minimum duration of therapy is 12 months, and treatment can only be stopped when there is clearance of the disease. In immunocompromised patients, the treatment is continued for as long as the immunosuppression cannot be reversed. And in HIV patients, the CD4 count should be at least 150 before treatment can be stopped. And urinary histoplasma antigen testing periodically can also help us decide when to discontinue treatment. So does adrenal insufficiency recover with treatment of histoplasmosis? No. Again, this is a study from SGPGI which showed that none of their patients achieved eucortisolemic state after treatment of adrenal histoplasmosis. Now coming to adrenal tuberculosis, this is the second most common infectious etiology of adrenal insufficiency in tropical countries. The patients present with classical symptoms of tuberculosis as well as adrenal insufficiency. The workup should concentrate on confirming the diagnosis of adrenal insufficiency and establishing the diagnosis of tuberculosis from the common sites of involvement, mostly pulmonary or extrapulmonary. CT abdomen would show bilateral adrenal enlargement, often with calcification if it is long-standing. So this is a patient who is currently admitted in our ward, a 57-year-old male who came to us last Saturday with weight loss, anorexia, vomiting, and hyperpigmentation. He had elevated serum creatinine, hyponatremia, hyperkalemia, and ultrasound showed left hydronephrosis. When he came here with the classical symptoms, we did his cortisol and ACTH. The cortisol was low and the plasma ACTH was 1200. CT abdomen showed bilateral adrenal masses with left hydroerythronephrosis. And so he underwent a PCN, and the urine expert TB PCR detected Mycobacterium tuberculosis. So he is currently on oral prednisolone after a short course of IV hydrocortisone and also on fluorocortisone along with first-line antitubercular treatment. So when we look at all patients with tuberculosis being a common problem in our country, what proportion of them actually have adrenal insufficiency? So there are two studies from Kashmir which have looked at patients with pulmonary tuberculosis as well as patients with extrapulmonary tuberculosis and found that none actually had definite adrenal insufficiency, but they found that the serum cortisol levels were lower among those with tuberculosis compared to controls, and also their adrenals were thicker. And both these problems resolved after the full course of antitubercular treatment. Another study from Kolkata found that among these patients, subclinical adrenal insufficiency was found in about 57%, while overt adrenal insufficiency was present in about 10.7%. And the serum cortisol negatively correlated with the radiological severity of tuberculosis. When we look at bilateral adrenal masses, what proportion of them are actually due to tuberculosis? This is a study from KEM Mumbai, which found that about 27% of bilateral adrenal masses are due to tuberculosis. So about the diagnosis and treatment of adrenal tuberculosis, the diagnosis is established by establishing mycobacteria in the common locations like from respiratory secretions or the urine, by microscopy, nucleic acid amplification tests like expert TB PCR, cultures, or histopathology from biopsy specimens. And treatment involves antitubercular treatment as well as glucocorticoid and mineralocorticoid replacement. A caution with regard to antitubercular treatment is that rifampicin increases cortisol breakdown to 6-beta-cortisol by regulating the cytochrome P450 enzymes in the liver. And this happens as early as 5 days of starting rifampicin. And hence, patients may develop acute adrenal crisis. So all patients with adrenal tuberculosis should be treated with double the dose of physiological glucocorticoid replacement. And also, it can trigger overt adrenal insufficiency in a person who has subclinical adrenal insufficiency. Hence, all patients with tuberculosis, it would be best to check a 8 AM cortisol before beginning antitubercular treatment. Very rarely, paracoccidioidomycosis has been reported. This is especially reported in Latin America, not much of a problem in our country. Lungs are the portal of entry. Again, bilateral adrenal masses. Histopathology establishes the diagnosis by demonstrating budding yeasts with the steering wheel pattern, and treatment is with itraconazole. Similarly, blastomycosis, lungs are the portal of entry of this dimorphic fungus. Diagnosis is by biopsy, and fungal cultures would yield the yeast-like organisms, which can be treated with itraconazole. Cryptococcus is an encapsulated yeast-like fungus, primarily affects immunodeficient hosts. The diagnosis is established by cryptococcal antigen test, and treatment is with fluconazole and amphotericin B. So in summary, endemic causes of adrenal insufficiency account for a large proportion of adrenal insufficiency in tropical countries, especially in the form of adrenal infections. And improved awareness has led to better detection and appropriate treatment of this condition over the last few years. And adrenal infections do occur even among immunocompetent individuals. Diabetes is a likely predisposing factor for adrenal histoplasmosis. Rifampicin can exacerbate an adrenal crisis and or unmask an adrenal crisis, and hence it's important to check the cortisol before starting antitubercular treatment. And steroid education in on managing stressful situations needs to be emphasized in all patients with adrenal insufficiency. Thank you.
Thank you, Dr. Asha. A great presentation. And you also kind of opened our mind and our eyes. There are so many distinct etiologies of adrenal disease that we all should be aware of. And then the world is becoming smaller and smaller, more contact, more communication, more travel. So no country, no continent in the world would be immune to etiologies from a different continent. And like Dr. Imperia said, COVID taught us that as well. If you have one virus in one country, that is not going to remain to that country. It can spread all across. But continuing with Dr. Asha's presentation, Dr. Imperia or Dr. Joseph, Dr. Sarah, any endemic forms that you see in your part of the world? Dr. Imperia first.
In the 80s, when we have HIV, we have a lot TB, TBC, and paracoccidoidomycosis, histoplasmosis, and all of these other things. Now we have less number of patients, but over the last 10 years, the TBC has increased again because of the bad control who has our governments. So therefore, we have more cases. And all the adrenal insufficiency that the doctor described, which was beautifully described, was because of the medications, which are quite often we see.
Thank you. Dr. Joseph, Dr. Abodo, any endemic forms in your part of the world?
Yes, adrenal insufficiency in tropical countries are a challenge. As you can see in the HIV prevalence in HIV endemic conditions, many cases of HIV was deceived about insufficiency. Never diagnosis. Or later, we recognize that dead because of this. So don't forget that HIV is still a common condition. It's still endemic. So I think we should have a specific presentation on HIV and endocrine diseases, especially in it's very common with different features part of tropical.
So we have our topic for the next webinar now, HIV endocrinopathy and perhaps tuberculosis endocrinopathy. So thank you, Dr. Jacob, for sharing that with us.
And COVID.
And COVID endocrinopathy.
And COVID.
Yeah. My comment about the presentation, excellent, Professor Asha. It's interesting to see a lot of mycosis as cause of adrenal insufficiency in the country, in India. Of course, I think previously when we were all training, our graduate and postgrad training, I think the awareness was poor. That's one of the reasons. Plus increased incidence of HIV in the subcontinent. I think globally, the prevalence of HIV-related illnesses are increasing as per the WHO report in a couple of days ago. I think we'll probably encounter these kind of cases. We rarely come across this mycosis as a cause of primary adrenal insufficiency here in the UK. But we see a lot of patients with, the immunotherapy-induced adrenal insufficiency, because for most cancers now, immunotherapy is the treatment of choice, and they crash their adrenal and pituitary and then come with acute adrenal crisis. I think if you look at our epidemiology now, we may be dealing with more cases of primary adrenal insufficiency as a part of immunotherapy than the conventional autoimmune disease. And we have to bear in mind that the adrenocortical antibodies has a relatively low sensitivity. But as Professor Asha was mentioning, if you have negative antibody, as we have recently updated in one of our reviews with Shahla Sheikh and Lakshmi Nagendra, I think we have to image the adrenal to look for malignant deposits as well as other atypical adrenal involvements, including tuberculosis. In any patient with the diabetes, they're all prone to develop this kind of immunocompromised related diseases such as fungal adrenalitis as well as tuberculosis. So very good presentation. Thank you.
Thank you, Dr. Asha. We'll move on to the next presentation by Dr. Imperia. So, Professor Imperia, we have seen that adrenal diseases, adrenal morbidity is part and parcel of human disease. We've also seen that there is a need for more advocacy, more talking about adrenal disease. And all our experts have highlighted how many aspects there are of endocrine health and endocrine disease, which we don't think of. But let's talk from a treatment point of view. What are the essential drugs for adrenal medicine? And how can we, make sure that these simple drugs are available across the world? Any insights from your side, ma'am?
Well, thank you very much for the opportunity, and congratulations for all the speakers, because they are very good as well as make easy my presentation. First, I will do several questions and answers through my talk. The first one is what we are looking for with replacement therapy for AI is to achieve the optimal glucocorticoids and mineralocorticoids in primary adrenal insufficiency replacement regimen to maintain quality of life during stress dosing, to avoid the adverse consequences of excessive replacement, and to prevent mortality, particularly from adrenal crisis, with education and preparations. Let's see, first of all, what is the potency of the available glucocorticoids. First of all, we will have the equivalent dose, the anti-inflammatory activity, mineralocorticoid potency, how suppressed HPA, the duration of action, and the plasma half-life. We have short-acting, which is hydrocortisone, 20 milligrams, and cortisone acetate, 25 milligrams, which is the anti-inflammatory activity is 1 for hydrocortisone. Mineralocorticoid potency is just 1, but the duration of both are between 8 to 12 hours. The intermediate acting is prednisone and prednisolone, which is 5 milligrams of each one, but the activity of anti-inflammatory is 4 times, and the duration of action is 12 to 36 hours. Methylprednisolone and triamcinolone is 4 milligrams, 5 times actions, and the duration of action is the same, 12 to 36 hours. We have a long-acting, which is the dexamethasone 0.75 and betamethasone 0.6. Both have 30 activity anti-inflammatory, and the duration is 36 to 72 hours. And the mineralocorticoid that we have is fluorocortisone, which is 2.0, 10 times anti-inflammatory activity, 250 mineralocorticoid, and duration the activity is 18 to 36. As we have regularly every day, we have patients, for instance, even more with this old adult that we have simultaneously, for instance, a pulmonary disease that they need inhalators, or they have simultaneous any arthritis, or either they have pain joint and they have intra-articular glucocorticoids preparation, or topical, as maybe for urticaria. And at the same time, they have systemic preparation for the same diseases or for something else. That combination is associated with high risk of hypothalamic pituitary adrenal axis suppression. So therefore, is going to be more susceptible to develop adrenal insufficiency and adrenal crisis, and it's difficult to, in that case, withdraw the doses. This is a very more easier to see. The risk of adrenal insufficiency may be depend of which glucocorticoid and the administration that we're using. For instance, if it's a short acting, is low risk. If it's moderate, is with the intermediate actions, and the high is with the long actions. The administration route with this low is with nasal, topical, and ophthalmic. Moderate is inhalators, and high with the systemic and intra-articular is high. So that is worry because many patients got intra-articular glucocorticoids. The dose and the duration of use and body mass index and age has to be taken in account. What are the options for adrenal insufficiency as therapy? The short-acting glucocorticoids should always be used as the primary treatment options. A total of 15 to 25 milligrams of hydrocortisone or cortisone acetate 20 to 35 milligrams in adult, divided in 2 or 3 times daily. When it's a hyperplasia, congenital adrenal hyperplasia is mostly highly glucocorticoid dose to adequate suppress adrenal androgen productions. The mineralocorticoids in that case, the only use is for primary adrenal insufficiency, are replaced with fluocortisone at the dose of 0.5 or 0.2 milligrams per day. It is important to know that hydrocortisone exerts potent mineralocorticoid action, while prednisolone only has reduced mineralocorticoids activity, and dexamethasone don't have a low at all. When we have a patient who already has primary or secondary adrenal insufficiency, we have to prevent whether they have an Addison crisis and what we can do. For instance, if we have a mild physical stress, for instance, intensive sport activity, or a mild cold that is just beginning with low fever, we can just take 5 to 10 milligrams of extra hydrocortisone. And when it's a mild physical stress and it's intensive sport activity and the common cold is getting worse, we can get 5 to 10 milligrams extra hydrocortisone. If everything is increasing and start to vomiting or get more ill, you can have 20, 10, and 10 milligrams of hydrocortisone through the day. And then when that is getting, for instance, you can have also moderate mental stress. For instance, fear of visiting dentist or nerve before an exam or job interview, we may get 2.5 to 5 milligrams of hydrocortisone. If it's severe mental stress, for instance, death of close relatives or funeral or traumatic experience, you should take 20 milligrams of hydrocortisone. And if the infection is getting worse and more fever, you have to take 20 milligrams of hydrocortisone immediately, and if it's an accident as well. But if you start vomiting or getting worse, you have to inject 100 hydrocortisone milligrams in intramuscular or subcutaneous. And if the patient start to lose consciousness or to be very, very dizzy, you have to inject the hydrocortisone and go to the emergency room. How to make diagnosis and management of AI and adrenal crisis in the emergency department? First of all, if it's just a new diagnosis, you should take a blood sample for cortisol and ACTH, and if you can, and if you have, which is quite difficult, I think, to make a cortisol test. When the patient is chronic adrenal insufficiency, with acute illness, you should add electrolytes as well. But if the treatment is with a new diagnosis, you should take hydrocortisone 200 to 300 milligrams over 24 hours, 100 milligram bolus, and 50 milligrams every 6 hours intravenous, and isotonic intravenous fluids and electrolyte with dextrose as needed. With this chronic adrenal insufficiency with minor illness, we just double or triple the hydrocortisone oral, or you initiate parenteral dose of 100 milligrams until they start to tolerate the oral. Of course, you have to give a volume and electrolyte repletions and start to get the hydrocorticoids when they start to tolerate the oral intake. That is, and recently this month, the European Society of Endocrinology and Endocrine Society of Joint Clinical Guidelines with diagnosis and therapy of glucocorticoid-induced adrenal insufficiency, which is very important. And nowadays, we come across, as my colleague recently saw, that with the new medication for cancer, we start to see more and more. The concept start from is the duration of glucocorticoids therapy considered to have a risk of adrenal insufficiency when it's more than 3 or 4 weeks. To have a risk for adrenal insufficiency because of the glucocorticoid induced, any dose equivalent to physiological daily dose, so greater than 15 to 25 milligrams of hydrocortisone, or 4 to 6 prednisone or prednisolone, and 3 to 5 methylprednisolone or dexamethasone 0.25 to 0.5 dexamethasone. You have to bear in mind that glucocorticoid withdrawal syndrome you may see symptoms that experience when lowering the glucocorticoid dose, especially when you taper it. And there is, or maybe because of the underlying disease, or maybe because your glucocorticoids that you have initiated. The recommendation for regarding taper in the systemic glucocorticoid therapy, they say not to taper a glucocorticoids in patient and short-term glucocorticoid therapy less than 3 to 4 weeks, no matter of the dose. The glucocorticoid taper for patients of long-term glucocorticoid therapy are tapered until approaching the physiological daily dose equivalent is achieved. During the taper dose, be aware that you may see glucocorticoids withdrawal syndrome. So in that case, you have to go back to the previous dose and be more conscious or slowly. We recommend in that case against routine cortisol testing. Patient taking long-acting glucocorticoids, so let's say dexamethasone or betamethasone, should be switched to short-acting glucocorticoids, so either hydrocortisone or prednisone. When the patient are on physiological daily dose equivalent and aiming to discontinue glucocorticoids therapy, you have to do or continue to gradually taper the glucocorticoid dose while being monitoring the clinical signs and symptoms on adrenal insufficiency. You have to be aware. Measuring a morning serum cortisol for confirm that the recovery of the axis of adrenal pituitary hypothalamus is recovery, and we suggest against routinely performing a dynamic test for diagnosis. Presenting the signs or symptoms of exogenous Cushing's syndrome are assumed to have glucocorticoid-induced adrenal insufficiency. Patients without recovery the HPA axis in 1 year, while a physiological daily dose equivalent and history of adrenal crisis should be evaluated for an endocrinologist specialist. We recommend against the use of fludrocortisone in patients with glucocorticoid-induced adrenal insufficiency. As for cortisol values as a guide, they suggest that the taste indicator recovery of the HPA axis if cortisol is more than 300 nanomoles per liter or 10 micrograms per deciliter, and glucocorticoids can stop safely. When the result is between 150 or 5 and 300 nanomoles or 10 micrograms, the physiological glucocorticoids dose should be continued and the morning cortisol repeated after an appropriate time, usually weeks or months. And they suggest that if the result is less than 150 nanomoles per liter or 5 grams per deciliter, the physiological glucocorticoids dose should be continued and then morning cortisol repeated after a few months. So the message to take home is be aware the risk of the glucocorticoids therapy inducing adrenal insufficiency with glucocorticoids preparation. Short-acting glucocorticoids, hydrocortisone, should always be used as the primary treatment options. Mineralocorticoids is only indicated in primary adrenal insufficiency, are replaced by fludrocortisone at the dose of 0.05 or 0.2 milligrams per day. When low, mild, or severe physical or mental stress is present, adjust dose of hydrocortisone oral or use parenteral. Duration of glucocorticoids therapy considered to have a risk for AI when it's greater than 3 or 4 weeks. It's not necessary to taper glucocorticoid in patients on short-term glucocorticoid less than 3 or 4 weeks. Glucocorticoids withdrawal syndrome may occur during glucocorticoid tapers, so you have to be aware. Patient taking long-acting glucocorticoids should be switched to short-acting glucocorticoids and then start to taper. Thank you very much.
Clinical practice and from Dr.
Sorry?
Yes. Thank you, Dr. Imperia. Wonderful talk. Thank you so much.
I think I stick with the time. I hope so.
Yes. Perfect. What time? Perfect. Thank you so much. So we've learned so many aspects of adrenal medicine. The disease is common. The complications are there. We need to investigate properly. We need to treat properly. And we need to focus on essential drugs as well. When it comes to essential drugs and to other aspects as well, alone as endocrinologists, we can't do much. We need support of other stakeholders. And seeking support of other stakeholders will be possible only if we ensure awareness, isn't it? And awareness comes with something called advocacy. Now, Dr. Jaco Bodo is an expert, a global expert in advocacy for diabetes care, for endocrine care. So, Dr. Jaco, over to you. What does the word adrenal advocacy mean to you, and how can we help you all? How can we help each other in ensuring that adrenal medicine gets its rightful place under the health sun, under the sun of healthcare?
Yes, according to the place of advocacy in adrenal disease, we should see it at many views. The first is at epidemiological point of view. Don't forget that many countries, many low and middle income countries involved in this situation are not any statistic, any data. So the first part is to have data on this frequent condition. If we have full data in this frequent condition, we have to manage the screening methods. Screening newborn people with congenital adrenal hyperplasia, for example, associated to congenital hypothyroidism and our diseases, as you know, well, should be taken into account in local level, but also in Africa's global condition. So we need different set of expectation to do this. The second thing I have to say is the methods of diagnosis and clinical aspect. It is also many conditions coming from adrenal insufficiency, but also tumor or upper secretions. You see different presentation according to secondary hypertension in young people, for example, due to hyperaldosteronism and other diseases, like Cushing syndrome, and so on. Don't forget that the symptom and the sign are not specific. So we should take care of some symptoms like fatigue. Fatigue or asthenia is a very, very common situation in people suffer for adrenal fatigue, hypotension, and hypoglycemia, vomiting, and diarrhea, also dehydratations. So we should put in place local guidelines, but also Afro-India or Afro-Asia guideline, because as you know, we have specific condition, tropical disease in such as tuberculosis, HIV, and other common infections, diseases, or antibacterial infections. Don't forget also that it is very difficult to diagnose most of etiologies because, for example, the 21 hydroxylase antibodies is not current access in many African cities. So we should move to universal health coverage, to have money, to have funding for many of, even in newborn to screen and diagnose congenital adrenal hyperplasia, even in aged suffer from autoimmune polyandocrineopathy, including, for example, Addison disease. And let's move to the medications. See that medication, most of the time, is used for all the life. So, cortisol, for example, have essential medicine advocacy that essential medicine using hydrocortisone and elsewhere should be fully supplied or needed in this way. Because some are in emergency condition, some are in chronic condition. And don't forget the last point and on the list on education. Education is the real problem of patients, but also it needs medical practitioners aware of these situations. So we need to train general practitioners. We need also to train nurses in that condition. The sensitizations is a remaining problem. Most of people in our condition, in low and middle country, are not aware of adrenal disease as we talk about. Sensitizations sensitize the populations, the people, the community of the commoners of this. And one of the most problem is using the scan screen. Scan screen African population, Black population, as I spoke about, is a very, very, very bad thing. And as on this condition, the politicians should take advice, take law, stop this bad crime for countries. This is my small talk of this. I see, it should be done in most of our countries, because we are not many money, we are not many health conditions diagnosed and to take care of such patients. Thank you very much.
Thank you, Dr. Jacko. And you've put things in perspective for us. We need to speak out, we need to speak together, and we need to make sure that adrenal medicine gets its rightful place. And this webinar that we've had today, this is one step in that direction. Of course, if you look at traditional wisdom from China, so what Confucius teaches us is small steps make a long journey. And every step is equally important. So this is a step that is equally important on our way towards improving adrenal health for everyone. But let's go through our panel once again, go with our panel, and one by one, we'll ask them what is the most important thing that you think that can be done for adrenal advocacy in your country and across the globe. So perhaps, Dr. Sarah, you'd like to begin. The single most important thing that we should do or we can do for adrenal advocacy.
Review, I think we should screen for primary aldosteronism. That would be one thing. Especially, let us begin with cases having severe and resistant hypertension. Then we can gradually include more cases.
So screening, that's an important take-home message. So at least screen, think like Sherlock Holmes for everyone with for everyone with hypertension. Dr. Joseph, would that hold true for everyone with metabolic syndrome as well? Your single take-home on adrenal awareness, adrenal advocacy.
I think that's very important in metabolic syndrome as well, especially looking for, especially those with slightly difficult to control hypertension, because many of the patients with metabolic syndrome may have associated sleep apnea, which is a risk factor for primary aldosteronism as well. So the prevalence of sleep apnea is between 16 to 25% according to some of the reports, but I would think it may be higher. So many of those patients may have primary aldosteronism, and screening for primary aldosteronism is important. And as Professor Abdu was mentioning, you should have regional as well as country-wise approach to every disorders, including in a resource-poor setting like African continent. You can't just do the tests like adrenal antibodies and all. So they have to devise local guidelines. I hope and wish this kind of global collaboration should help us to develop guidelines for each country and have a developing country perspective.
And that actually increases the need for us to be more clinically vigilant and to hone our clinical skills. Because if you don't have laboratory backup, then your clinical skills have to be stronger.
Yeah, that's exactly what we have been taught by our old great teachers who never used to rely upon the labs. But endocrinology is basically biochemical science, so we'll have to devise some baseline investigations. But of course, we have to always consider the patient factor, including the economic aspects.
Professor Asha is head of department of one of our most prestigious medical colleges. So it's a medical college and a department of endocrinology, which is famous across the world. So, Madam, your comments, adrenal advocacy, adrenal awareness, from a student's point of view, budding endocrinologists, budding physicians, what single take-home would you share with our young endocrinologists and physicians, Madam?
I think as teachers, we should encourage our students to develop a clinical eye to looking at patients' problems. That we should always keep up the clinical medicine as the first in our approach. Recently, I would like to say that we had a patient with primary adrenal insufficiency who had hyperpigmentation and whose ACTH came back as 10. And we repeated the test, it came back as 168. So this is the importance of clinical medicine, that you believe your clinical skills more than
skills. Yeah. So look at the ACTH report, but don't ignore your clinical acumen as well. That is the first in the hierarchy. Dr. Jacko, you are one of the leading policy makers and planners for the International Diabetes Federation. Now, adrenal and diabetes have a lot in common. Adrenal disease can cause diabetes. Diabetes can cause adrenal disease. So from a diabetes perspective and from an IDF perspective, what should we focus on in adrenal advocacy, adrenal awareness?
First, I would like to speak about diabetes conditions. You should notice that when you diagnose diabetic patient, you should move to etiological features. Before saying that this patient has type 1, type 2, or specific or endocrine or secondary diabetes, you should move to the real diagnosis. So it is very important. You can find if it is an endocrine diabetes endocrinology or everyone, every else. You understand?
Yes, got it.
And the second phase is in front of any endocrine disease. You can have heredity leading to diabetes condition or hypertension condition or else. So this is the directional condition you have to talk about. And don't forget that when I speak about HIV, for example, HIV antiretroviral therapy can cause diabetes. A patient suffering from HIV can have also diabetic condition. And if you have diabetes, the two conditions is more affected by infection disease, tuberculosis, mucosis infection, and every infection, especially adrenal infection disease.
That's true. Thank you. So two concepts that we use. One is adrenovigilance. Adrenovigilance means that we should be vigilant about adrenal disease in each and every patient who comes to us. Anyone coming with hypertension, with palpitations, with asthenia, low blood pressure, whatever it is, do think about adrenal before you move on to other aspects, or at least think about it clinically, even if you don't investigate. That is being adrenovigilant. And the second thing is what we call glucocrinology. So when you look at glucose metabolism is influenced by each and every gland in the body, the pituitary, the thyroid, the gonads, the adrenals. And the concept of glucocrinology states that when you look at diabetes, you should not forget the other glands. All said and done, diabetes is an endocrine disorder. Though when you look at modern discourse, you would be excused if you think that it is just a disorder of the heart. It is a cardiovascular or a kidney disorder. So we should not forget the endocrinology of diabetes and glucose homeostasis, and we should include that in all our CMEs and all our educational programs. Dr. Imperia, Madam, if you could share your perspective. You represent the International Society of Endocrinology. So what can we do at the ISC level, at the global level, to spread endocrine awareness and advocacy?
Yes, but I think, for instance, there is a problem with many other specialty, let's say traumatologists, rheumatologists, that just is easier just to give glucocorticoids to improve pain or whatever. But you have to be in mind that maybe you will get in the end problems, and you will don't solve the problem that he has been asking for from the beginning. So they have to have more experience and more information about the adrenal consequence with the glucocorticoid excess. So, and I believe this has to be first. Second, the patient has to be well informed how to manage the dose, what to do with the crisis, what to do when it doesn't feel like well as the day before. So they have to be confident to manage their dose. And on the other hand, we should give more information, to the rest of the medical world in order to be aware of the high blood pressure, of the obesity problems that is related with adrenal, or the metabolic syndrome that every day is even worse, the obesity that is almost 70% between obesity and overweight. So that is every day our mission with everybody, with the medical doctors and as well as to the patients.
This take-home message is very important. it is our mission, like Madam says, to educate the patients and the public, and also to educate all our physicians, all our colleagues. And that is what we have tried to do in today's webinar. From my side, I would like to thank each and everyone who has logged in. I would like to thank our experts from across the world, all the way from Venezuela and Spain to UK, United Arab Emirates, and India. And I would like to thank Team Samarth for their support in helping us observe World Addison's Day. Over to Team Samarth for the vote of thanks.
Thank you, Dr. Kala. Yeah, thank you, Dr. It was a pleasure listening to all of you.
Team Samarth, a question for you before we conclude. What does the word Samarth mean in your vote of thanks? So what does the word Samarth mean in Hindi or in Sanskrit?
Samarth, as per my understanding, Samarth means being capable.
Yes. So that is what we try. We try to achieve capability, self-capability.
Yeah, muchas gracias por la oportunidad.
Gracias from India as well. And merci beaucoup, Dr. Jacko. Thank you, everyone. Team Samarth, please.
Yeah, Shrutika, please.
Et j'espère vous revoir au congrès d'Abidjan pour l'Afrique en octobre. I hope to see you in October in Ivory Coast for African Endocrine Diabetes Congress.
Yes, Dr. Jacko is inviting all of us to attend the Pan-African Congress in October, which is scheduled for Abidjan in Côte d'Ivoire, West Africa. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you.
Have a nice day, everybody.
Team Samarth.
Good evening, everyone. As we conclude this program, I would like to extend my deepest gratitude to all those who have contributed in making this event a success. So first and foremost, a special thanks to our esteemed panelists. Your insights and expertise have provided us with a comprehensive understanding of adrenal insufficiency from various global perspectives. A very special thank you to Dr. Kalra for his support and guidance throughout the planning and execution of this entire event. As one professional representative from the pharmaceutical industry, we firmly believe with what Dr. Abodo commented in his session on adrenal advocacy, where he highlighted the fact that all the stakeholders, be it your doctors, primary healthcare providers, patients, pharmaceutical companies, policymakers, healthcare insurance companies, they all have an important and indispensable role in fulfilling our common objective, which is to promote and advocate for adrenal health. One important drug in management of many adrenal disorders is corticosteroids. And the current rampant use of steroids warrants and highlights another critical need, that is steroid stewardship. Dr. Kalra and Dr. Sahai who are present with us today. In the year 2022, they have published an important article which outlines the importance of steroid stewardship. In their words, steroid stewardship is the systematic effort to prescribe and monitor glucocorticoids in a rational manner while balancing the effects with potential risk in patients who require glucocorticoid therapy. So it is a collective responsibility to put into action what they have emphasized upon in their editorial on steroid stewardship to limit both underexposure as well as overexposure of steroids in patients who require this therapy. With this, I thank all our lovely delegates who have taken time from their busy schedule to attend this webinar. A big thank you from Samarth Life Sciences family, who are the manufacturers of hydrocortisone, that is Hyzone, and fludrocortisone, that is Floricort. We look forward to a continued collaboration to promote awareness on adrenal disorders and adrenal medicine. Thank you so much.
Thank you.
Thank you. Thank you all. Good night.
Goodbye.
Goodbye. Have a nice
Thanks all. Thank you.
Bye-bye.
Bye-bye. Have a nice
Good night. Good night. Good night.
Good night.
Good night.
Good night to Indians, but we are still alive, awake for some more time.
Good afternoon. Good afternoon in Africa.